Okay, thank you, Louise.
Thank
This is an important conversation that we need to have, and I'm going to say a bit about why I think it's important, and then what we might do about it, basically. Yes, I am the chair of the NHS Confed. I've been the chair since April, actually, and I'm enjoying it. It's a great organisation. We represent the leadership of well, I suppose the waterfront of health and social care, acutes, mental health, community, the lot. That's what we do. I'm also the co-founder and executive chair of Visionable, and Visionable is a visual platform, visual collaborative platform. Actually, we're about transformation of the way services are provided to people. Our mission basically is to bring healthcare to everyone, everywhere. Now, there's lots of tech companies that say that. We're actually doing it as we speak, because our platform will do things that others cannot do. We're also a partner with AWS, actually. So I was listening earlier to the contributor from that company. So why is this important? And why I'm winding down. I'll let you into a secret. I'm winding down the amount of talks I give on the issue of race and diversity. And the reason for that is that I don't want to become a kind of talking head for race. I think race should be discussed by people who generally don't look like me, but generally actually lead many of our institutions in the health and care space. And I just think that we need to make this a critical leadership issue. So the thing that I always say is that leaders in health and care are either leading some of the people some of the time, in which case they should be paid accordingly, or they're leading all the people all the time, which is what they should be doing, and that's what my tax dollar pays for. And in that, the technology and digital health space is critical. It's the future of healthcare. There are only three challenges facing the healthcare systems in the West, I'd say, and that is equity, by which I mean, not equal access, but access which is appropriate to the needs of the individual. Access, by which I mean the design and delivery of services and the design of the workforce necessary to run those workforce, and digital. And the reason why it's in that order is that if digital isn't helping the first two, why are we buying it? Why are we talking about it? Why are we using it? So that is my entry point, and why I think it's so important. In February, I edited an edition of the BMA magazine, and that magazine was focused on the issues of race as they manifest in the health system, and in particular referenced sort of not just healthcare methodologies, but we looked at digital in particular. And I was shocked. I'd not taken a deep dive into some of this stuff, but we had academic articles presented to the magazine as editor. I read them, and one of them was about the skin cancer and how algorithms used to detect skin cancers are basically biased, not just in their outcome, but in their construction. And the reason for that was that the people writing the algorithms were generally white men. And it struck me that that is shocking, but it clearly is a failure of the leadership, and it's a failure of leadership that I'm paying for, and you're paying for, and cancer patients, particularly BME cancer patients, will pay for, and it's probably one of the reasons why Black people have a poorer experience of cancer care and poorer outcomes. And there are many other examples in the health and non-health systems where digital services are designed by monocultural teams, generally white, generally male, for people who will not be monocultural and will not be generally white and generally male. So this issue is not a sidebar. It's not something that you do on the side of what you do, and it's not a nice to have. It's not something that is fluffy, to use a word that's often used when you talk about these things. Basically, if you don't have a diverse team, you don't have a competent team. It's as simple as that. Your team is not competent, and it's not competent to deliver and design digital interventions in the health service. And the first question that any purchaser of digital interventions using my tax dollars should be asking is, who are the team? who they consist of, how are they led, and what evidence does the leadership give me that will mean that the digital device, digital system, digital strategy that's been applied will be for all the people, all the time, everywhere. And it's just mission critical. There isn't another way of looking at it. We know from the research into the way teams work that diverse teams bring a fresh perspective. And how many challenges do we have in the health and care space that require a fresh perspective? We know that coronavirus is one of those areas. We know that the first 10 people to die in the NHS were black and minority ethnic people. We know that the leadership is consistently, with maybe one exception, white. We know that has led to the design of interventions that have effectively missed out those people most likely to die, and so they have died. We know that the way in which we measure and we use digital tools to measure the impact of leadership and the impact of decision making often leaves out the very people that we need to be engaged the most, and then we discover it, and by then it's too late. They are dead, they are injured, they are disenfranchised, and they are leaving. We can't afford to do that in a system where 20% of the workforce are BME, and where we have a multicultural society in many of our towns, cities, villages and places. It is not just immoral, it is expensive, and it is a waste of life, and it is a waste of money. So what do we do about it? We know that fresh perspectives are important. We know that diverse teams improve decision making. We know that diverse teams actually create better outcomes. We know that not just in the case of digital health, we know it in case of company health. We know that collaboration is better in diverse teams. And we know all this not because I'm guessing it, because there have been many studies into this issue, not least by Professor David Williams of Harvard University, who will regale you at length as to the science behind what I've just said and the fact that it is objectively true. So there is no excuse. It is an excuse remover. There are excuse removers out there that say that diversity in the delivery of digital health and the design of digital health is a must-have. What surprises me when I look across the way in which we procure digital health in the NHS, the way in which we invite procurement of digital health doesn't seem to take this into account. And certainly, speaking as the chair of a digital service provider and a values-driven company like Visionable, I have to say I'm shocked at the way in which these values seem to be absent from both the commissioning, procurement and application of digital services in the NHS. Can I say it's getting better? Well, I'm an optimist. I'm far too lucky to be a pessimist, as I often say. But the optimism is tainted by experience to date. And this matter isn't just a matter for the people listening to this useful conversation. It is a matter for the procurement people. It is a matter for the commissioning people. It is a matter for the chief exec. It is a matter for the CIO. It is a matter for the general leadership of our health and care system. So what should we do about it? Well, there are certain things that work and there are certain things that don't work. And I'll tell you what they are, because the ones that don't work, I'm sick of hearing about. They curse my eardrums, actually. We know that diversity training and evaluations don't increase diversity in either race nor gender. We know that the research has been done. I would refer you again to David Williams's work on this. He carried it out in 2006. We also know that mentoring and networking has very modest effects. Now, I'm not against networking or mentoring, but we need to understand that they have very modest systemic effects when it comes to organizational change and team development. The most effective strategy are the introduction of mandatory programs and programs with explicit authority, accountability and support from the leadership, and that is monitored. We know that that is the most effective intervention if you want to increase the portion of minorities and women. I say women because in the tech world there is a dearth of women on the front line, and there are some excellent programs that are doing great work to support that. because of course when people talk about women, they often say to me, well, you know, there's an increased, we have a increased numbers of women in our system, and I always say, well, which women? And actually usually doesn't mean black women. So if you look at the work of the STEMettes and the excellent Anna Marie Imafidon and the work that she's doing to bring black women into the digital world, we see there, again, another execution mover that can be applied by everyone, and certainly the leadership of the digital health systems to change things. So there is no excuse. There isn't a reason, a rational reason why building diversity into digital health shouldn't happen. It should happen. It should be happening now. It should be visible. And if we are not doing it, if you are not doing it, if you are not determined to do it and getting the support to do it, then I would argue vehemently, actually, about your competence as a leader. And that might seem a blunt thing to say, but you know, we're running out of time, folks. We need to get this right, and we need to get this right now. So there are things you can do. When people tell me that they're having problems recruiting, I say, well, why don't you apply the Rooney Rule? Why don't you say we want to see black and minority ethnic candidates in shortlisted, or reasons given why such managers or experts or whatever aren't on the shortlist. And this rule was applied in America. It's called the Rooney Rule because the man who invented it, Rooney, invented it because the American Football League was actually, while there were black footballers, there were no black football managers. And so he applied that rule. And over the course of a year, 2 years, the numbers of black managers in the American Football League increased, and the performance of those teams increased, and it was a benefit all round. So again, something that you can do, an execution mover. I think we should look to our universities, and we should look to our learning, seats of learning, and we should put our arms around those black and minority ethnic talent in those universities so that they feel encouraged. I've yet to see a leader, and I've studied leadership for some years, I have a master's in it indeed, I've yet to see a leader who hasn't had an arm put around them at some point by somebody and said, I think you're good, and I think you can do this, and I will show you the path, and I will sponsor your leadership through that path until you get to the position that I want you to get to. The only people for whom that doesn't happen, and yet they appear in exception, like me, are black people, basically. Black men and black women in particular tend not to have those arms around them, either on their journey or indeed when they get there. Digital health, that has to stop. I think I should end there, and I think I've said my piece. Apologies if it appears to be a rant. It's hard to speak to people when you've got a blank screen in front of you and a slide saying the Surrey Network and Yorkshire and Humber AHSN. What I can say is you can't afford to stop. This is not just about talking about it. This is about doing it. Lives are at risk. The quality of lives are at risk. And the funding available, and there is lots of funding available for digital health in the NHS, will be wasted if we don't get this right. So get it right, folks. Thank you very much.
That's great. Thank you so much, Victor. And I do know exactly what you mean. It's very disconcerting speaking to a laptop when you can't see anybody or hear anybody. But please, we've got lots of chat going on. We're all really enjoying your talk, and it's great to hear from you. So I know that you talked about some of the mandatory programs for leadership support and for monitoring, and I think, you know, it's leaving us all with, okay, so how do we measure this? How do we start to measure this? And you know, just some of those sort of practical things that we're going to, you know, have to make sure that the NHS has. And I think that the NHS People Plan that Paran has launched, I think that does touch on some of those areas. So I think that resonates with their plan as well.
Is that a question? Or
well, if you'd like to comment on it, please do.
Well, I think the People Plan is a good start. I think it needs to be followed up by a procurement plan, a commissioning plan, You know, it needs to be seen as running through the strategy, the forward plan of the NHS. It's not just about people; it's also about what those people do, what they buy, how they buy it, and who from. It's not difficult. On the measurement, you are right. In the NHS, what gets measured gets managed. But you know, it's fairly simple. If you're let's count the numbers. Let's look at the digital teams in the NHS, and not just in the NHS, but the suppliers to the NHS. And it's the leadership. It's not just a numbers issue. It's not about saying we have 50% of our teams. It's about who makes the decisions, who makes the strategic decisions in this team, who makes the strategic decisions in this company, and are they qualified? Are they leading all the people all the time? If they're not, why are we buying services from them? It's not difficult.
Absolutely. And so thank you again, Victor. And I'm really sad that you're not going to be doing as much of this kind of stuff. So I feel very grateful that you've given us your time, and hopefully we will see you again. But in the meantime, thank you so much.